I'm sort of trying to get the wires all straight. I'm deaf on audio equipment usually, so I hope I don't break anything. Everything is in the handout unless I tell you otherwise, so you shouldn't need to take any kind of notes. Let me find, how do I control the slides? Is it on the microphone? Okay. Yeah.
Technology's going to get it.
So I'm very challenged in that regard. Okay. My talk is on delirium and electrolyte abnormalities in the elderly, and what I think I'll do is spend about 30 minutes or a little more than half the time on delirium and the rest of the time briefly talking about the more common electrolyte abnormalities. So what I'd like to do is briefly present a case, then talk about delirium itself. What is it? What are the symptoms and signs? What are the causes? And how do we treat it once we do recognize it? And then I'll talk about 3 specific electrolyte disturbances, hyponatremia, hypernatremia, and hypercalcemia, specifically as they affect older patients. Let me go ahead and just start with a case presentation. This is kind of a story. So it won't take long, but I think it illustrates several of the points that will come up later. Mrs. Garcia is a registered nurse, and she has a neighbor named Mrs. Smith, who's an 80-year-old retired cafeteria worker. Mrs. Smith, her neighbor, has been fairly healthy until about sometime 6 months or so ago when she suffered a myocardial infarction. She was admitted to the hospital with her heart attack and found to have hypertension and diabetes, which she had not known about before. She recovered uneventfully, thank goodness, and was discharged on hydrochlorothiazide and chlorpropamide for her diabetes. Both conditions were supposedly well controlled when her blood pressure and her finger stick glucoses were checked. However, over the last few days, she developed symptoms of a viral gastroenteritis, some diarrhea, some cramping, and some vomiting. And she called in her doctor, who sort of recognized that condition and phoned in a prescription for some Phenergan and advised a liquid diet for 1 or 2 days and to call in if things weren't better. When Mrs. Garcia drives to take her kids to school, she notices that Mrs. Smith is outside in the yard in her nightgown and slippers, and it's about 30 degrees outside, and this is clearly unusual. She drops her kids off and comes back and checks on her neighbor. At this point, the lady's on the porch and doesn't seem to be in any distress, but when Mrs. Garcia asks Mrs. Smith, why are you out in your nightgown on such a cold day? Mrs. Smith mumbles a few things like, well, I think the boys took it over there. And she kind of gently ushers her into the house and can see that the woman has not either taken care of her personal hygiene or cooked or cleaned or done anything that she would normally do over the last few days. And Mrs. Smith is normally a meticulous person who's capable of doing everything she needs to do. So furthermore, her speech, it's kind of rambling and it doesn't always make sense. And she sometimes seems like she's talking to people who aren't there. So let's say this lady has sort of new onset of what seems to be disorientation, sort of rambling and illogical speech. She may be hallucinating, and she's neglecting her care in ways that she never would have done before. Mrs. Garcia, the neighbor, calls the doctor's office, but unfortunately they are at a conference. They're not there that day, and so she decides to take Mrs. Smith, her neighbor, into the emergency room to see what's going on. And a very nice and conscientious young physician in the emergency room examines the patient, finds that vital signs are 108/60, the pulse is 95, other vital signs are normal, takes Mrs. Smith into the room and spends a good deal of time with her, and comes out and tells Mrs. Garcia that, I think your friend really needs to be in a nursing home. She can't take care of herself anymore. She has no idea why she's here, and she can't even tell me what's wrong. I think we better call a social worker. Mrs. Garcia says, well, she was actually fine a week ago. Could you check some other things? And the doctor said, well, yeah, I guess that's a good idea. And gets some lab work and finds that the sodium's 118, fluoride 88, bicarb 30, potassium 3.3. Glucose is 74. This is middle of the day by now. BUN is 28, and creatinine is 0.9. So that's the story. Mrs. Smith appears to be delirious. And So this is a fairly common condition in hospitalized elderly. It occurs in 30 to 50%. It's hard to know how often it occurs in the community or in the nursing home setting. I say in hospitalized patients, it's at least 30%, and it's usually not recognized by the people who are taking care of them. Well, let me go back. There are some other names for delirium that are more colorful. It is an acute confusional state. Other names are reversible madness or acute brain failure, which is really, in a sense, what it is. Usually the problems are outside the brain, but there's a sort of a generalized failure of brain function. It's a transient disorder of cognition and attention, so that there's a global disturbance of cognitive function and attention. The sleep-wake cycle is usually disrupted so that the person may be drowsy or somnolent in the day, may be agitated at night, or may sort of alternate between those two. And usually there's either increased activity so that the person is actually sort of agitated, hyperactive, picking at things or wandering aimlessly, or may actually have too low a level of activity. And those are the ones we often miss. Usually the hyperactive ones are diagnosed and the other ones are just not. There are diagnostic criteria for delirium, and they're listed on the handout. These are from DSM IV, and basically it requires that there be a disturbance of consciousness, which involves a reduced clarity of awareness of the environment, a reduced ability to sustain, focus, or shift attention. There needs to be some worsening of the person's cognitive function or the development of some kind of perceptual disturbance, such as hallucinations, delusions, misperceptions of things in the environment that are not due simply to a dementia that was already there. And then the disturbance needs to have developed over a relatively short period of time. In the handout, there's a table that compares sort of delirium and dementia on several of these sorts of domains. The history and physical or lab findings should provide evidence that the disturbance is caused by a medical condition, a medication side effect, an intoxication from a substance, or substance withdrawal, or some combination of all of those things. Okay. Let me go through. This is, I say, my fairly simple-minded but clinically useful mnemonic to remember the causes of delirium when I'm actually seeing patients. I just spelled it out and then sort of attach the causes. D is for drugs, which by that I don't mean illegal drugs. I mean the ones that we prescribe most often. And I'll go into some detail about which drugs are more likely in a few minutes. E is for electrolyte and mineral abnormalities. L is for low perfusion, and by that what I mean is anything that reduces blood supply to the brain. It can be severe anemia, either from, most likely from blood loss, but from other causes. It can be volume depletion from an illness or diuretics. It can be a heart attack. Particularly people who have an underlying dementia often present with their heart attacks with altered mental status as a primary symptom. So that's low perfusion. I is for infections, and it can be any kind. Pneumonias and urinary tract infections are probably the most likely, but even an influenza or a severe viral illness can do this in a susceptible person. One of my most enjoyable patients I ever took care of was a 99-year-old retired optometrist who was a very bright and interesting person, but got the flu and was truly delirious. And someone seeing him during that time would have thought he was demented or psychiatrically ill. But all it required was for the illness to clear, and he was his sort of normal, brilliant self afterwards. So like I say, even a minor infection can do this. Go ahead and write in impaction under I as well. Occasionally fecal impaction can cause delirium as well. R is for respiratory problems, and by that I mean anything that lowers oxygen supply to the brain. So pneumonia, heart failure, pulmonary embolus, let's say anything that lowers oxygen. I is for impaired sensation. Sensory impairments such as loss of visual and auditory input, even in young healthy people, if they're bad enough, can cause people to begin to hallucinate and develop altered mental status. And that impaired sensation on top of several other things can certainly exacerbate the problem in an older patient. Like I say, I have to apologize for, but it's unusual presentations of primary CNS disease. delirium is not usually from something primarily going on in the brain. It's usually one or several systemic processes that cause it. Occasionally, stroke, meningitis, or brain hemorrhage can cause delirium. Usually there are other signs that would suggest this, though. And M is for metabolic problems. By that, very elevated blood sugar or low blood sugar, or abnormalities of thyroid hormone, excess of adrenal hormone. Those are the main ones that would cause delirium. Of the drugs that cause delirium, anything that's known to have CNS effects is likely to do it. In addition, cardiac antiarrhythmics, anticonvulsants, H2 blockers, and nonsteroidals are reasonably likely to. There's a long list in the handout. It would not all fit on the slide of drugs known to cause delirium. Generally, any drug that the person has been started on recently is suspect, essentially anything. Okay. Let me go back to Mrs. Smith. So she has, let's say she has a delirium, and she has at least 3 or 4 of these causes. She's been started on a new drug, which is ephedrine, which can have CNS active properties. It's a phenothiazine type of drug. She has hyponatremia, or low sodium, and that can certainly cause altered mental status. Because her rapid pulse and relatively low blood sugar in a person with hypertension suggests that she may actually be volume depleted. That could contribute. And let's see, the third one is her blood sugar is 74, which is maybe too low for an older diabetic person. So I say there are at least 4 reasons why she might be delirious. Okay. Let me talk a little bit about sort of how to evaluate delirium when it's recognized. When I say recognizing it right now is a big part of the problem. But once it is, it's not a technologically difficult thing to evaluate it. It requires a good history, physical exam, and some type of mental status and exam, and I don't think it matters that much what kind. It's just so long as one is done. Review medications and stop or reduce everything that can be stopped or reduced, especially those that are known to cause delirium. And then a targeted lab evaluation, a blood count, electrolytes, renal and liver function tests, a blood sugar, calcium, and phosphate should be sufficient in most patients. It's reasonable to do a urinalysis and chest x-ray to look for infection, given that UTIs and pneumonias are very common causes, and cultures can be done if appropriate. That's really, I say, that suffices in most patients to help you know what the causes are. Further testing can certainly be done if no cause is found on the initial sort of evaluation. If there's any hint that there's a respiratory problem, it's reasonable to check a blood gas. If there's any reason to think that there might be a cardiac cause, an EKG ought to be done. And then the other things are really low yield after that. If there's some reason to think there may be a substance intoxication, toxicology screens or drug levels are reasonable. If there's reason to think that the person is hyperthyroid, then thyroid function tests are reasonable. If you think that they have liver failure, a pneumonia is reasonable to do. And then B12 and folate are not really likely causes of acute mental status change. If the person has had anything that makes you think they've had head trauma, or if they have any localizing neurologic signs, it's reasonable to do some sort of brain imaging study, probably a CT, because you can usually get that more quickly. And if you suspect or think that there may be seizures, you can get an EEG. EEGs are always abnormal in people with delirium, but you don't usually need to do an EEG to figure out that that's what's wrong with them. And then if there are symptoms or signs of meningitis, it's reasonable to do a lumbar puncture, but again, that should not need to be part of the standard evaluation of people with delirium. Okay, this is to remind me to talk a little bit about treatment. This is an ad I actually hate from a medical journal, and it says change upsets me, and then the next page it says handle with Haldol. And I say that it's not usually as I say, it's really aimed at people who are demented, that this is what you should do. I say it's kind of a bad example. That's not the first thing to do. The first are sort of evaluate and manage usually these multiple interacting medical conditions that are causing the delirium. Second is to provide a tranquil environment. The thing that's probably most useful is actually having somebody who knows the patient stay with them all the time. And I say if that's not possible, it's, some hospitals and some places actually hire private duty sitters to sit with delirious patients and be there all the time, which is considered sort of appropriate care for them. Many places we don't and can't do that, even though we probably should. Soft lighting so that the person can remain oriented but still sleep at appropriate times. Minimizing noise, especially like overhead sort of PA system noise that you'll hear people kind of getting delusional about and talking back to it and all kinds of things like that. Try not to disrupt sleep by waking people up to check vital signs and give meds in the middle of the night if you don't really need to. If they're still sleeping normally, leave them alone. Discontinue all non-essential meds. Maintain proper food and fluid intake. Avoid physical restraints. There are some studies actually on physical restraints and delirium, and it looks like independent of other factors and adjusting for how impaired the person was when they got restrained, restraints actually increase the risk of a person becoming delirious. That doesn't mean they're never necessary. There are times when they will be, but minimizing them is useful. Monitor and treat pain and discomfort. Sort of try to keep the person oriented by having their glasses and their hearing aids there and working, and providing cues in the environment that help them stay oriented, and then restore a normal daily routine. I mean, all of that is really common sense stuff, and it should work. It's good care, and this is my sort of maintain orientation, kind of labeling everything clearly. There aren't very many studies on treatment of delirium to tell us whether all these things we think are a good idea work. There are a few. There's one study of a combined sort of medical nurse and nursing intervention where delirious patients were identified and then sort of randomized to get this intervention or not. And what it involved was sort of assessment by either a geriatric psychiatrist or a medical geriatrician, and then follow up by a geriatric nurse specialist, and on a daily basis with recommendations. Pretty much the list we said is what they would recommend that people do, and those recommendations were followed about 70% of the time, which is pretty good, actually. What they found was that the patients who got this intervention improved, their mental status returned to baseline a little sooner. So at a couple weeks out, they were better than the people who didn't get it. At 8 weeks out, they were the same. So it may have helped a little. It wasn't really impressive. The other intervention, sort of controlled trial of this sort of thing, was a nurse intervention with, again, a clinical nurse specialist who would sort of do all of these things, but in addition would go himself or herself to the patient every day, help that person sort of remain oriented, and in addition, get the patient out of the room and walk with them every day, in addition to all these med reductions and everything else. And that one, again, it used a very crude measure of mental status, and it was kind of stacked against them that they would find anything, and sure enough, they did not find any effect on mental status. What they did find was substantially better physical function at the end of hospital stay and even farther out. So it did appear to be a beneficial intervention and may have improved the delirium, although they did not. I say because of the measure they chose, they couldn't prove it. And the third thing was a study. So there have been a few studies done in surgical patients, again, trying to use these kind of orientation measures to prevent delirium from happening, and they've been only modestly effective again. So I say there's not a whole lot of hard data to support these things. I say they're common sense recommendations and they're good care, but we don't know for sure how well they work. I wanted to talk for a minute about sort of who's at risk for delirium, which people are at the highest risk, because I think there's enough data to know that. Age in and of itself is a risk factor, so age over 70 does place a person at increased risk, and the older you are, the higher your risk of delirium. Another pretty well established risk is pre-existing dementia, so that people who have some impairment already are at much greater risk of becoming delirious when they get sick. The other are severity of illness, so people who have severe illness, again, are more likely to become delirious. So those three are pretty well established. Alcoholism, malnutrition, and pre-existing functional impairments are also probably important, but not as important as those first ones. Okay. The last thing I wanted to say about delirium is that, we think of it as a transient problem, but there's more and more data that it's not really transient, that even at 6 months out, only half of the people who become delirious have gone back to their baseline mental status. So I say it seems to have the potential for sort of lasting bad effects on patients, in addition to the fact that people are more likely to become functionally impaired in their activities of daily living and are more likely to end up going to a nursing home, even if they didn't start out at one, if they become delirious. Okay. Let me just, at the end, what I'd like to do, because I think there will be a few minutes, is to talk a little bit about formal ways to look for delirium, and I'll hand out some of a couple of the instruments that people have proposed and talk about that a little bit, but it's not essential. Let me go on to fluid and electrolyte problems and get through that and then go back to it. Why are older people susceptible to fluid and electrolyte problems? One reason is decreased total body water, which is closer to half of total body weight rather than 60%, which is what we're usually taught. Because of that, drugs that are water soluble will tend to have higher concentrations. Second, in response to water deprivation, older patients have a reduced thirst response and are less likely to maintain their fluid status on their own. They also have a decreased ability to conserve sodium in situations of volume depletion. Conversely, if they're given excess water, they're less able to get rid of it because of changes in kidney function. And then finally, they're more likely to be malnourished. So all of these things are kind of a setup to make them more susceptible to fluid and electrolyte problems. Hyponatremia is the most common fluid and electrolyte abnormality in hospitalized elderly, and it happens in 2 or 3%. Not all of these are severe, and most of them are not symptomatic. However, it does have a mortality of 10 to 50%. That's a broad range because a fair amount of the mortality is associated with what the underlying cause for the hyponatremia. Basically, hyponatremia results from an abnormal sodium to water ratio. There are 3 basic types. Hypovolemic, so what you might sort of call dehydrated, although really it's hypovolemic, so that there's too little sodium and there's also too little water, but the sodium deficits are greater. That's one of the things that may have been going on in the case I presented. Second is euvolemic, or mild volume excess. So the person actually has a normal fluid status or very slight fluid excess, but just below sodium. And second is hypervolemic. So these are the edematous states, where there's excess sodium and even more excess water. The way people respond to hyponatremia depends on a couple things, mainly the rate of development and how long it's been going on, so that people tend to tolerate hyponatremia that develops slowly pretty well, and it's considered acute only if it's been present less than 48 hours. Okay. The symptoms and signs, and you'll notice sort of a fair similarity between the symptoms and signs of each of these things. Muscle cramps, weakness, nausea, vomiting or hiccups, headache, confusion and disorientation, then potentially followed by seizures and coma if the hyponatremia is severe or acute. Complications of hyponatremia are of 2 types. One is, or 3 types really. One is because it's associated with underlying disease that has its own, these diseases have their own series of consequences. Second, acute severe hyponatremia causes brain edema, swelling. It can cause herniation of the brain with respiratory arrest and permanent brain damage or death. Unfortunately, the converse of that is the osmotic demyelination syndrome, or central pontine myelinolysis, which occurs when you correct hyponatremia. It occurs most commonly when you overcorrect it or correct it too rapidly, but it can happen even when correction has been as properly done as possible. It was first described in 1949. An alcoholic patient in alcohol withdrawal and pneumonia was admitted to Boston City Hospital, was treated, seemed to get better, and then 2 or 3 days later developed a spastic paralysis of the arms and legs and respiratory problems, and died about a month later. When the autopsy was done, there were lesions, sort of symmetrical lesions in the pons that accounted for the neurologic deterioration that this patient had. And that's fairly typical of the course of this syndrome. The patient comes in hyponatremic, gets corrected, seems to be doing better, their mental status resolves, and then 2 or 3 days later they begin to develop paralysis, may require intubation or tube feeding during that period, and may or may not recover. Some do recover fully and some do not. So those are the potential bad consequences. Drugs that cause hyponatremia, there are several mechanisms. The ones that have an antidiuretic hormone enhanced or mechanism are chlorpropamide or diabetes, which is one of the drugs that this older patient was on. It's a drug that we still use sometimes to treat diabetes because it's really cheap and you can give it once a day. And it's fine for a lot of patients. It's not good for old people because it has a very long duration of action and because it does cause hyponatremia in a fair number. I say for middle-aged and younger patients, I would still consider using it though. Tolbutamide, which is another oral hypoglycemic drug, also does this. Some of the cancer chemotherapeutic drugs, and then Tegretol or carbamazepine is one I've seen fairly often to do this. Drugs that cause hyponatremia by other mechanisms, probably of these, the thiazide diuretics are the ones that I've seen them have the most problem. And your typical patient who develops hyponatremia with thiazide diuretics is an older lady with hypertension who's been recently started on it for control of blood pressure, and then develops significant hyponatremia. It resolves when the drug is stopped, and if you start it again, it'll happen again most of the time. So people who develop this just can't take those. Non-steroidal anti-inflammatories can, tricyclic antidepressants can, although I really have no idea of the mechanism. Okay. The signs of hypovolemic hyponatremia are pretty much what you'd expect. Rapid pulse, hypotension or orthostatic hypotension, where there's a 20-point drop in systolic blood pressure or a 10-point drop in diastolic pressure when the person goes from lying down to standing. Low urine output, dry mucous membranes, poor skin turgor, which that to me is not a reliable sign in the elderly because skin turgor changes with age anyway. It's reasonable in pediatrics, but not in the older population. Then an increased ratio of BU into creatinine. Causes of low volume hyponatremia, either sodium's being lost through the kidney or somewhere else. Diuretics, intrinsic kidney disease, vomiting, diarrhea, sweat, wounds with a lot of fluid and electrolyte loss. The causes of hyponatremia with essentially normal or slightly increased volume are hypothyroidism, cortisol deficiency, excess water drinking, and this is in psych patients primarily, and I've dealt with this a few times. Post-surgical, mainly because of hypotonic fluids that are given during surgery, but also there's some recent work that suggests that actually there are differences in the way the kidney handles salt and water, even in the absence of being given hypotonic fluids, so that the people who are most susceptible to the post-surgical hyponatremia are actually younger and middle-aged women who are going through surgery. And it can happen even when they're not given excess water. Post-TURP, or prostate resection, which is due to the hypotonic fluids that are sometimes used as irrigation for the prostate bed as the surgery is being done. Okay. And then the syndrome of inappropriate antidiuretic hormone, in which the pituitary puts out antidiuretic hormone even though the sodium is low and the serum osmolality is low. This can occur with any kind of pulmonary disease, basically pneumonia, cancer, inflammatory disease, anything in the lung, and pretty much any kind of CNS disease. In addition to pain, cancer, post-operative state, or drugs, some of which I talked about. And then increased volume, this is supposed to be hyponatremia, that's an error on the slide, can be caused by acute or chronic renal failure or cardiac or liver disease, basically. Let me briefly talk about treatment. There are two key questions. Is the person having symptoms, and how quickly did the hyponatremia develop? If it develops slowly and they're not having symptoms, then treatment should be similarly slow. If the volume's low, isotonic saline with monitoring of electrolytes and treatment of the underlying illness or discontinuation of the drug. So that would have been appropriate for the patient we saw. She's somewhat volume depleted, probably because of a GI illness and a diuretic. And I say this would have been appropriate treatment for her in addition to a couple of other things. Hyponatremia with normal or slightly increased volume, again, mainly you treat the underlying cause. And if they're mildly symptomatic and, again, not severe, you can also water restrict. And then the edematous states, these are not usually acute hyponatremia, and you generally treat the underlying cause. So there's, acute severe hyponatremia with seizures, coma, or marked change in mental status does require more aggressive treatment. And I think what I'll do, I've pretty much included in the handout the numbers and details of how to do that. And I've actually changed it from less than 12 milliequivalents for 24 hours to 10 because that's probably even a safer level of correction, and that's in the handout. Hypernatremia is a little less common. It occurs in 1 to 2% of hospitalized elderly. It has a higher mortality than hyponatremia, mainly because most of these patients have severe underlying illnesses. The symptoms and signs are restlessness, irritability, followed by lethargy, muscle tremors, hyperactive reflexes, and then seizures or coma. Basically, you can iatrogenically give the person too much sodium and make them hypernatremic, or else they have inadequate water intake and or excess water loss. Those are the ways you can get it. In older patients, the causes are most commonly febrile illness with increased insensible loss plus debility that makes them unable to get water and drink. Second are chronic debilitating illnesses from stroke or dementia with, again, poor fluid intake. Some people consider hypernatremia in people who are in nursing homes as a sign of neglect, that this means that the person is getting bad care, and that's not always true. It does mean that the person's getting inadequate fluid intake, and certainly if it's unrecognized and unanticipated, that isn't good care. Although, at the end stage of almost every disease, eventually people will develop this, and that doesn't necessarily mean they're neglected. Tube feedings with inadequate free water or parenteral nutrition with inadequate free water can also cause hypernatremia. And then finally, if you give hypertonic fluids intravenously, you can develop it. Again, for older inpatients, pneumonia, dehydration, and stroke are the three things that are usually associated with hypernatremia. Let me see. So I don't think I need to go through that. Okay. So pretty much what I covered. For treatment, again, I think what I'll do is, I have all of the information in the handout in terms of how to calculate the deficit in body water and then sort of the speed at which to correct it. Okay. The final abnormality I wanted to talk about briefly is hypercalcemia. It occurs in between 0.5% and 1% of the population at large. Most people who have it have no symptoms and aren't sick. They may have vague chronic symptoms, or occasionally when it's risen quickly or to a very high level, there may be acute or severe symptoms. It's in the handout just sort of how to adjust the measured calcium for levels of albumin to look at that. Symptoms. These sort of the chronic symptoms are mostly GI in nature: anorexia, nausea, constipation, abdominal pain, bone pain may also occur, and people may develop kidney stones and symptoms from those. The acute symptoms really have to do more with cognitive impairment, confusion, weakness, and lethargy. And like I say, those can be from acute rises in calcium. Really, you can group causes of hypercalcemia into the common and the not so common. And the common, there are only two: hyperparathyroidism and cancer. That's really it. And most in the outpatient setting, most of them are hyperparathyroid. In the inpatient setting, that figure may not be accurate. Less common are medications, so that lithium and thiazide diuretics or excess vitamin A or D can cause hypercalcemia. Granulomatous diseases like sarcoidosis can do it. Immobilization in people with underlying bone problems can, and then the milk alkali syndrome, where people take in sort of milk and lots of calcium-containing antacids, can do it. So those are the common. Of the two common causes, hyperparathyroidism and cancer, it's usually not that hard to differentiate the two. If you know the person has cancer, that's likely the cause of it. If they've had elevated calcium for a long time and have not been particularly ill, or the elevation is mild, it's likely not to be cancer but to be hyperparathyroidism. And then you can measure intact parathyroid hormone, and that's an easy and very accurate way to differentiate the two. Cancers causing hypercalcemia: lung, breast, head and neck, esophagus, kidney, lymphoma, myeloma, and then genitourinary cancers. If people have no symptoms and the levels are not markedly elevated, it's reasonable to treat underlying causes or remove those. Most are hyperparathyroid, and they may not need treatment at all, just depending on the level and whether they're having bone complications or other symptoms. Severely symptomatic patients do need to be treated. They're all significantly volume depleted and dehydrated and need fluid replacement as a priority during the first 24 hours. If volume overload is a potential problem because of underlying disease, or you want even more rapid excretion, Lasix or loop diuretics can be used. And then anti-resorptive agents need to be added early. And I think I won't go over the dosing on those. Let me just go back a little bit to delirium for a few minutes on treatment. We talked about the common sense measures that we think are a good idea but aren't proven. I want to talk just for a minute about drugs for delirium. The Handle with Haldol picture was, like I say, partly just a joke and partly sort of that I don't like it, but sometimes drugs are needed to keep people with delirium safe. If they're a danger to themselves or to their caregivers, or their symptoms are so bad that they're interfering with care in a serious way, drug treatment is probably going to be needed for a while. There are two classes of drugs listed in the handout, a couple of neuroleptics and then a couple or three benzodiazepines. And there's not a whole lot of good clinical research on which drugs to use for delirium, and the only good control trial I could find was actually on delirium in HIV patients in the hospital, comparing different treatments. What they did was, like, HIV patients in a lot of ways develop all these same problems as elderly patients. They're very susceptible to the delirium. They get hyponatremic when they're in the hospital. There are a lot of similarities, actually. They compared haloperidol, Haldol, chlorpromazine, which is Thorazine, and lorazepam, which is Ativan, in a randomized controlled trial in AIDS patients with delirium in the hospital. And what they found was either the Haldol or the Thorazine improved symptoms of delirium significantly, and lorazepam made it worse. So at least my recommendation right now is, unless a person has alcohol withdrawal or benzodiazepine withdrawal as a cause for their delirium, I would tend to use the neuroleptics in very low doses if you need to use a drug for it. For people in alcohol or benzodiazepine withdrawal, of course you would use Ativan or Valium or whichever of those you feel clinically comfortable using. say there's not a whole lot to go on in comparing those, but very low dose neuroleptics may be the best thing to do if you have to use a drug at all. You may, let's say that they do have some risks, but are fairly safe short term. Let's see. Okay, so let me just go back. Like I say, these are the causes. If you recognize delirium and remember those, like I say, you won't miss anything important in assessing the patients. The main thing is to recognize it. Let me go ahead and hand out a couple of delirium assessment instruments that people have developed and talk about them for a minute. I think they're probably enough for everyone, although my copier is real slow, so I didn't get quite as many as I did on the handouts. There are two of these. One's called the Confusion Assessment Method, and one is called the Delirium Rating Scale. The first one, the Confusion Assessment Instrument, is probably the better validated and the more practical of the two. And what it does is it asks you to assess the patient sort of as you're doing everything else you're doing, including a mental status exam of some sort, and then just judge whether there's been an acute change from baseline, whether they had difficulty focusing attention so that they were distractible, couldn't keep track of what was said, was there disorganized or thinking as evidenced by rambling or incoherent conversation, illogical flow of ideas, or unpredictable switching from subject to subject. And so at least for scoring this, if both 1 and 2 are present and either 3 or 4 are present, you can diagnose delirium based on this instrument. This is designed for use by any person in a clinical setting. There's not, once they're sort of familiar and trained in the concepts, it doesn't require a psychiatrist or physician or any particular background, but like I say, any person sort of competent in a clinical setting can do this, whereas the other one, the Delirium Rating Scale, was originally designed for psychiatrists to use and is a little more involved. The only advantage to the second one is it gives you kind of a severity rating because it's a numerical scale, which for research purposes is useful, for clinical purposes not necessarily. And then the last thing I included was part of a neuropsych battery, which is a TRAILS test, A and B, it's a connect the dots is what it is. These have been used mainly in hepatic encephalopathy, so people with liver failure and altered mental status from that, and they do correlate with severity of hepatic encephalopathy. I say the first one is sort of just you connect the numbers, and the others you have to alternate 1A, 2B, 3C, etc. So it's a little harder. I say these are tools that people have used to measure and diagnose delirium in a clinical setting. I don't think they have to be used. I think that, when I read hospital charts and my patients have become delirious in the hospital, if I look back 2 or 3 days or nights in the nurse's notes, it's there. I mean, it was recognized even then, even though maybe on morning rounds it was not. But if you look at the nurse's notes from especially the night shifts and say, patient wandering aimlessly in room, picking at clothes, seems more confused. I mean, that's it. And if you can just say people can early on act upon that, put a name on it, and sort of do the workup, it would probably be very useful. I think nurses are recognizing it in the hospital, but maybe that communication and sort of follow-up is not occurring with medical staff. Okay. I think I'll stop. It's a little bit early, although my clock is a little faster than that. And just answer any questions if there are any. Okay. Well, yeah.
I'm just curious. Why did you not include the other D when you say the depression in the elderly?
I guess because I've seen it more as a cause of what appears to be dementia than delirium, but I guess you're right. It could present as an acute change. That's a good idea. I've seen it more as what seems to be a subacute or chronic dementia type change. Have you seen it present acutely?
No, most cases I have seen is like more drug related.
Yeah, but that's a good point. I may add it next time.
That's a really good one.
Okay. Anything else?